So without further ado, I'm going to give you a little bit of an overview of PDA management in the preterm neonate. And I think I'm going to let you be the judge of exactly whether to treat or not. The key question from my perspective is obviously whether I might be able to convince you that there is actually no evidence for what we do. And a lot of what we do is based on individual clinicians and center-based management rather than actual evidence. Just to give you a little bit of a flavor of current trial evidence. So what we know is that for babies over 28 weeks of gestation, there's about a 70% closure rate for PDA. So spontaneous closure is quite high. I'm going to take you through a little bit of the natural history of how a PDA actually progresses. But under 28 weeks of gestation, approximately 70% of neonates will have a PDA. Some of whom will have a hemodynamically significant PDA, which will cause problems later on in life. There is currently no trial evidence that actually shows causation between PDA and outcomes like intraventricular hemorrhage, spontaneous intestinal perforation, NEC, chronic lung disease, or ROP. There have been over 60 randomized controlled trials, the most recent of which has been done by my colleague, Dr. Samir Gupta, which is the Oscar trial. And actually, there is no high quality evidence that treatment of the PDA in an extremely preterm baby actually reduces mortality or improves outcomes of chronic lung disease, ROP, NEC, or long-term neurodevelopmental outcomes. There are, however, studies which actually show that NSAIDs are effective in actual treatment and closure of the PDA. Now, there is a very big problem with contemporary trials of PDA. And the main problem that we have is when you look at the placebo group, a large number of babies in the placebo group go on to receive treatment. And that means when you look at long-term outcomes or outcomes like NEC, chronic lung disease, there's a huge amount of contamination in the placebo sample that will actually dilute those outcomes and then make it difficult for us to interpret whether there should be significant differences or not. An ideal trial would involve management where we do not intervene and we do not treat the PDA at all. And there are actually very few studies that have been done to look at no management of the PDA in literature. I will be presenting one today. There are, however, single center studies done by colleagues Afif in Dublin, Dr. McNamara, which actually show that when you use judiciously symptom scores along with judicious use of echocardiography, you can identify an extremely high-risk group cohort of extremely preterm neonates where treatment done at the appropriate time not only improves outcomes, but actually reduces the incidence of long-term problems like chronic lung disease, as well as the incidence of NEC. This study, in particular, the last one, which was done by Afif and his colleagues, Ned and Guzman, has actually shown reductions in both chronic lung disease and NEC when the PDA is treated using that strategy. If I also talk about the difficulties in interpretation of contemporary PDA trials, I think a big problem for us is the inconsistent definition. So we all interpret the hemodynamically significant PDA in different ways. We know that there is significant inter-observer variation in echoes. And a big problem from our perspective is, what do we treat when we treat the PDA? Do we treat the high hemodynamically significant PDA without symptoms? Do we treat the PDA in context of symptoms? Do we treat a PDA that's diagnosed on echo? Also, are we treating size or do we need to clarify the effect of the shunt? And I'm going to talk about that in a little bit more detail. So there is without a doubt in my mind, having worked in 9 different centers in India, the UK, Vietnam, as well as now having joined the Cornish Hospital over here, that the PDA has an effect. In my mind, the PDA is designed to offload the preterm heart so that the systemic circulation in the fetus actually is able to receive blood flow so that the placental circulation can oxygenate it. It was never designed to actually be managed in the preterm baby. And with progress in resuscitation, we're clearly starting to resuscitate babies as small as 22 weeks. We intubate them, we give them surfactant, we drop the PVR, and what happens is this PDA basically shunts into the lungs and causes systemic steal, which then creates problems with the gut, creates problems with shunting into the lungs, causing chronic lung disease. Steal causes problems with spontaneous intestinal perforation, NEC, and then we can have systemic steal, which actually steals away from the cranial circulation, promoting IVH. So a lot of problems that theoretically we think might be an issue Now, if I compare the baby born at 22 weeks, who we tube and ventilate and give surfactant and reverse the shunt, that baby will have exposure to a hemodynamically significant PDA for a much longer time than a 28-weeker, where the chances that this duct will spontaneously close are much higher. So clearly, what I want to take you away from is the spectrum which says that every baby with a PDA has to be treated in one way. Actually, what we've got to become better at is defining what a hemodynamically significant PDA and symptoms look like in babies between 22 and 24 weeks of gestation versus babies who are more mature, where there is less impact and where we think there is a higher chance of spontaneous closure in the context of not then exposing them to the side effects of treatment. I can guarantee we still haven't got it right, but we are developing an approach to that. So, without a doubt, I think you'll agree over here, for those of you who know how to do echocardiography, that you can see from our perspective a very large duct over here. Now, this is a duct that's left-right shunting, and what is perspective is that we have a good understanding of the natural history of a PDA. So if I take you through the fact that most preterm babies over 28 weeks will often, when they're born, have a bidirectional shunt across the PDA because the PDA has been supporting systemic circulation to allow placental oxygenation. As this baby becomes 6 to 12 hours, and this is my echo experience of having echoed babies like this at this duration, is often the shunt reverses. And that's because we've altered the natural history of respiratory distress syndrome. We tube, we give surfactant, we're quite aggressive the smaller the baby is. And even babies between 22 and 24 weeks, my experience is have ducts that are shunting from left to right, probably bidirectional, more left to right at this particular stage, and starting to actually flood their lungs. For the more mature babies, above 27 weeks, we get restriction of the PDA. There's a slightly higher incidence of spontaneous closure. And what you get is this restrictive flow pattern with an increasing pressure gradient and a higher velocity, which kind of we call the restrictive ductal pattern. On the other hand, the less mature babies say between 22 and 25 weeks, will often have a more pulsatile pattern on the echocardiography, which basically indicates that you've got significant left-right shunting and you're flooding the lungs. Now, this is obviously a pattern that we, when we echo, worry about. And what we have to demonstrate from our perspective is what impact this is having on the baby to decide whether we want to treat the baby or not. This is classically how the ductal Doppler pattern progresses. That is a closed duct, so you can only see pulmonary blood flow over there. But this is the progression that you might see, say, in a baby who's over 27 weeks where the duct is spontaneously closing. I think this is the most important slide of my presentation today. And what I'd like to highlight to you is this is a study that's been done by SOM, which basically compares the impact of a hemodynamically significant PDA, the duration for which it is open, and the impact on the baby when the baby is 23, 24 weeks versus the baby being 27 to 28 weeks. And you can see that when this study was done in a reasonably large sample size of babies, we have a hemodynamically significant PDA open for over 40 days. So enough time to flood the lungs, contribute to chronic lung disease. If it's big enough, steal away from the gut, predispose this baby to NEC. If it's big enough, steal away from cranial circulation. So more likely to have an impact in this group of babies as compared to this group of babies. I mean, in 27, 28 weekers, the duration of exposure is 40 days. The hemodynamic significance and the cumulative incidence of the actual impact is much less. So where does that take us to? So I think one very important aspect I'd like to highlight is that we have seen preterm babies, and this is a baby that we treated in Southampton, where we did not elect to treat the duct. And clearly, at about 5 weeks of age, we had a right to left shunt in a baby with severe pulmonary hypertension, at which time our cardiologist said, "You missed the boat, Dr. Sharma. We're not going to be able to treat this duct because it's offloading right ventricle." So how do we balance treatment? And I'm going to move through this slide very quickly. So you can opt, if you're one center, never to treat ducts. And I know for a fact my colleagues in Edinburgh never treat ducts. For a fact, they actually, number of duct ligations that they have done over the years is in single figures. On the contrary, in Southampton, we're a center where we can actually ligate ducts on the unit surgically. We do about between 15 and 30 a year. There is the options, obviously, between of prophylaxis, treating the duct immediately after birth, There is the option of early targeted treatment where you do an echo and the baby's not yet developed symptoms, yet you use ductal size to determine whether you'd like to start treatment. And then there is the intermediate group of babies where you let the peripheral vascular resistance drop, the baby develops symptoms, and you use echocardiography in the context of symptomatology as well as demonstrating ductal effect to decide whether you want to treat. And then there are those babies who become ventilator dependent later on and have late symptomatic management. And that could be conservative management. It could also be surgical management. Now, I'm just keen to see with a show of hands over here. How many of you, anybody never treat their ducts? Forget the duct. Thou shalt not treat the duct. God shall take it away. Anybody over here? Okay. Anybody who practices prophylaxis at the moment? Indomethacin prophylaxis? No? Okay, what about early targeted treatment? I'm just curious to see with a show of hands. So we've got a few colleagues here who actually practice early targeted treatment. Clearly, the benefits of that are you can prevent the duct from getting bigger. If you practice it, and we, for babies over 28 weeks, actually use a high dose ibuprofen oral protocol of 20-10-10. Under 27 weeks, we follow the short protocol. But optimizing it might actually reduce the exposure of the duct. The problem is, if you use this approach in babies over 28 weeks, where the duct has a 70% chance of closing, are you then exposing those babies to unnecessary treatment and the side effects of ibuprofen? I've never used indomethacin in my career. On the other hand, for the babies between 23 and 26 weeks, the failure rate in my institute with the use of normal dose ibuprofen, it's about 60%. So less than 40% of babies in that situation actually respond to treatment. We then go on to early symptomatic treatment, which in my mind could be a late course of medical therapy, which again, my experience is rarely works, versus a conservative approach, which is fluid restriction, PEEP, provision of diuretics, trying to offload the left ventricle, and actually from our perspective, ameliorate any effects that the duct has. So if we take all these strategies, I would say that more or less in the UK at the moment, I'd say most centers would opt to follow early targeted treatment or a conservative approach. I don't know any center in the UK that currently practices prophylaxis. And then there is a group of babies who are either ventilator dependent, where we demonstrate that there is significant overload of the lungs, who then become candidates for surgical ligation. And surgical ligation in the UK follows two approaches: surgical operative closure on the unit, or what we call as percutaneous closure, which is done at a slightly later age. And I know centers in the Brompton are actually doing it for babies as small as 1 kilo. My approach, and the approach that we followed in Southampton, that's what I'd like to share with you, is we almost always consider the PDA in the context of symptoms. We've recently introduced the use of a symptom score that we've imported with permission from the Children's Hospital of Philadelphia, which actually looks at the score and prompts us to do echoes as early as day 3 to as late as day 14. And it might mean that the 24-weeker who extubates, who is in air, who's managed with CPAP, may well on echo have a hemodynamically significant duct. But actually, if it's not symptomatic, without bonding crunches, I'm hoping that it's got a high peripheral vascular resistance that's actually preventing a significant shunt. And that's not a baby from my perspective, where actually we would think of treatment at that particular stage. So a key thing from our perspective is it's individualizing your approach to that baby, its gestation, really trying to define whether the PDA is the problem here. And a good example is, a 4-week-old baby with severe chronic lung disease. You do an echo, and it's got a wide open PDA that's 3 millimeters on Doppler. But actually, the problem here is the CO2 of 10 with bad chronic lung disease. Now, that baby might be a better candidate for steroids, especially if the ductal velocity is low. So I think it's very important for you to individualize treatment. And then it's the benefits of versus the risks of that treatment. And that's where I would say that a PDA ligation and surgery has huge risks and has to be considered very, very carefully, something that we discuss very closely with the parents. In terms of the bigger picture, as I've discussed, there's absolutely no evidence that treatment of a PDA actually improves any of the long-term outcomes. How do we proceed? So we assess our PDAs not just based on size, and I would argue that you need to move away from that if you're practicing echocardiography in the context of a symptomatic neonate. What you really have to do is demonstrate not just the effect of the shunt, but also the effect on other organs like the heart, the brain, the kidneys, the gut, and the lung. And our standard approach is actually to evaluate all of these factors. In Southampton, our first echo is always performed by or under the supervision of a pediatric cardiologist, which kind of means that all my images, structural, will be reviewed by them. And in particular, what we don't want to miss is a duct-dependent lesion. What we also don't want to make or miss is the risk of coarctation of the aorta. And I can tell you when the duct's quite large, especially in a 22-weeker who's 450 grams, the assessment of that can be quite challenging at that age. It needs serial follow-up, very careful management. Arch-sidedness, if you're planning to ligate the duct, is key. Now, these are the effects for those people who think the duct doesn't have an effect. So what you can classically see here is left-sided volume loading of the heart, significant mitral regurgitation. But if you look at those pulmonary veins, massive. Left atrial dilatation in the crab view. But these are just impacts on the heart. And what I would normally do is I would evaluate that alongside evaluating seal. Now, what you can classically see is a suprasternal aortic view with a massive duct. When you put a Doppler on that, what you're looking to see is basically that image there of ductal reversal retrograde flow. The reversal can also be demonstrated in the celiac and the superior mesenteric axis, but be wary of doing that. The angle of inclination can be a problem for people who actually practice echocardiography. My question, and this is a question to the audience, is it all about size? How many of you do echocardiography here for your ducts? Lots of people, I'm not surprised. So how many of you look at size and size? Does size worry you? No. So 2.2 millimeter duct, pulmonary end in a 23-weeker day 3. How would you manage that? I'm just curious. Go for it.
Now that you put that in context, it's very different. So if it's only size, the size of the baby size of the pulmonary artery, 2.2. That's like really bigger than the pulmonary artery. It will cause easy. Now, 90% maybe what I'm going to say.
So my question there is, and thanks, that's really kind of you to answer that, is will it? And the reason I asked that question is day 3, you might have high peripheral vascular resistance. You might have a wide duct, which might be low velocity. So actually its impact on the lungs and scale might be much less. Now, there is at least one study that's been done by Martin Klukow, which actually shows that if you analyze a duct on day 3, it's more than 2.2 millimeters. It is predictive of non-closure, but my actual experience is very different to that. And having followed ducts up, we often see large ducts vascular resistance drops. If you're more mature over 28 weeks, a lot of these ducts will close spontaneously. So actually, as opposed to kind of just relying on size, what we've moved to do is trying to assess what the effect of the shunt is. And a very good example is, this is a classically overloaded left ventricle in a term baby, which is causing problems with heart failure. This is a baby who we just could not get off beat. Significant mitral regurgitation. We also had evidence of retrograde flow, fluid restriction, diuretics weren't working. Eventually we opted to get this baby surgically ligated and we had amelioration of symptoms. A key important thing from our perspective was making sure that these symptoms weren't due to any other cause. So, excluding that this baby doesn't have, a structurally abnormal heart due to other reasons that might be causing significant left ventricular hypertrophy and left atrial volume overload. Just again, another example of, an echo, so significant left atrial enlargement, but what you can see is going up the septum. Now, sometimes you might have more than one shunt which is contributing in that situation and causing problems. And that might actually mean that diuretics aren't going to work. More than one shunt might actually necessitate that you have to aggressively manage the PDA and think of ligation. This is a 27-weeker who had 2 shunts where we had to do surgical ligation. Again, surrogate markers of the impact, LAO ratio, left ventricular dimensions, all of these things can actually be done. There's quite significant inter-observer variation. So we never use this in isolation, but the other aspect is demonstrating heart function. And of late, what has come into view is the use of left ventricular and diastolic function echocardiography, which if done quite well, can actually give you more information about volume loading of the heart. Last but not least, the use of mitral inflow, again, ductal steal. all of these things from our perspective might be helpful in us assessing the impact the PDA has on the gut, the impact we feel that it might have away from the brain, and then putting a holistic picture together to kind of say, well, it's not just this duct being big, there's actual impact of this duct on the baby that's going to necessitate that we intervene medically or surgically. I think a very critical aspect of this management is making sure you don't miss a duct-dependent lesion. Now, this is a baby who was transferred to us from another tertiary center where they treated the duct without getting a full structural echo. So this baby was transferred to us because of concerns with regards to NEC after having had treatment with indomethacin. And clearly from our perspective had very high lactates, very, very weak femoral pulses, and had developed coarctation very early for the baby to have developed NEC at day 10 anyway. Now, just to end, what I'm going to do is contextualize the approach that different people take. So some of you would argue there's absolutely no reason why we should give babies indomethacin prophylaxis. We're subjecting those babies to unnecessary side effects. Over 27 weeks, those babies have a very high chance of spontaneous closure themselves. Between 23 and 27 weeks, there's a very high risk of perforation, renal failure, acute complications. And then if you haven't done a full structural echo and you give prophylactic indomethacin in 24 hours, you close the duct, you're doomed. The baby's doomed. My argument is what you've got to look at is what your center suffers from. And there are centers who have very high rates of IVH. They have to look at, and the reasons for them then practicing indomethacin prophylaxis might be they want to reduce the risk of IVH. But my worry about that is, again, what are you measuring? What objective parameters are you using to say that the duct was the problem there? Early treatment and late treatment are practiced quite widely. And again, what I'd say is my take-home message to you would be that if you're deciding to treat the duct, don't look at echocardiography alone. Look at the symptoms, look at the impact the duct has at that particular point of time. Individualize your management to that particular baby. Think about the long-term complications of the treatment that you're potentially giving the baby. And where possible, minimize those side effects. So our protocol is a 3-day course of Brufen, not more. We will stop and we will give the baby time. And in my experience, babies between 23 and 28 weeks, like I said, about 40% of babies will respond, 60% will fail. We might opt to give them paracetamol on the next occasion. But actually, if that duct now does not have a significant shunt effect, really, do I want to treat that duct? Can I move this baby forwards? Can I get him off the ventilator? Are there other strategies that I can use? Is there something wrong with the baby that's keeping the baby on the ventilator other than the duct? So it's really important that we do not get fixation. We don't get fixated with the duct in isolation, that we individualize to that baby at that particular point of time. My experience of late treatment and conservative management is probably the most widely practiced way of managing hemodynamically significant ducts after the first 3 weeks of life. It is probably also one of those treatments which has the least impact in terms of side effects. I think what is very important is if you're practicing it, you really need to think very carefully about what your end-term goals are. Are you planning to treat symptoms? Are you planning to treat the echo? In my opinion, what you should be doing is trying to treat both. Surgical ligation. Can I just say that I come from a center that has practiced surgical ligation for 33 years. These babies, they become very sick. In my experience, if you're ligating a duct to reduce chronic lung disease late, it doesn't work. So, parents come to us expecting that the duct will get ligated and this baby will come off the ventilator and the chronic lung disease will get miraculously better. I'm sorry, that is actually not what happens. These babies become very, very sick. They often need inotropic support. They have very severe pain. They have severe pulmonary hypertension. We have now moved to a very non-surgical, non-interventionist approach. And I can tell you for a fact that of those 15 to 30 babies that are ligated, they're all from outside our center. Very few babies in my center in Southampton actually have surgical ligation of the duct. To those people who don't treat ducts at all, so there's this saying that they have, that Jesus said, "Thou shalt not treat thy PDA, and the Lord shall take it away." So can I just say that any dictum which says all or none, which kind of says, I will not treat ducts, or I will treat 100% of ducts, is putting babies at risk. What you have to decide is where this baby is at this point in its journey, what the duct is doing, clinically what you think the impact of the duct is, and then decide on benefits and risks whether treatment is actually in this baby's best interests. Thank you.